Hi, let's talk about subacute thyroiditis, also known as the Quervain thyroiditis. Subacute thyroiditis is an inflammation of the thyroid gland. In contrast to Hashimoto's and Graves' disease, it is not a classic chronic autoimmune disease, but a postviral inflammation of the thyroid cells. Let's start with how patients typically present. Patients present with acute symptoms. The most frequent and clinically relevant problem is severe neck pain, caused by inflammation of the thyroid gland. In over 60% of cases, the pain is unilateral. It may be present on swallowing and is particularly pronounced on palpation of the neck. In some patients, the pain radiates to the jaw or the ear. So sometimes patients may present with ear pain, but actually have thyroiditis. Additional symptoms may include fever and a pronounced feeling of illness with flu-like symptoms and myalgias. So what causes the inflammation? Thyroiditis de Quervain often appears 2 to 3 weeks after a viral upper respiratory tract infection. Syndromes that manifest in a delayed fashion like this are classified as postviral inflammations. The actual viral infection has been eliminated, but out of unknown reason, another organ, in this case the thyroid gland, gets inflamed. Some sources consider molecular mimicry to be the leading cause of this type of thyroiditis. It means that viral antigens look similar to proteins from thyroid cells, which leads to an attack against your own thyroid cells when antibodies have been produced. What happens during this infection? Due to the inflammatory process, thyroid follicular cells and colloid, a fluid between the cells storing thyroid hormones, are destroyed, leading to the release of thyroid hormones into the bloodstream. That's why at the beginning of the disease, symptoms of hyperthyroidism may occur. These include, among others, tachycardia, palpitations, sweating, heat intolerance, or sleep disturbances. But symptoms can also be rather nonspecific. The hyperthyroidism can also be demonstrated by blood tests. Because of the release of preformed hormones from the cells, free T4, FT4, and free T3, FT3 are elevated, while TSH is suppressed due to negative feedback. Later in the course, the inflammation subsides and transitions into a euthyroid phase with normal thyroid values. In the end, when inflammation is gone, in about 50% of cases, a hypothyroid phase may follow, with elevated TSH and decreased FT4 and FT3. But this usually resolves spontaneously over time. Let's answer the question how subacute thyroiditis is diagnosed. In most cases, the clinical symptoms lead the way. Severe neck pain, especially anteriorly, and a pronounced feeling of illness with fatigue, myalgias, and possibly fever is typical. In most cases, an upper respiratory tract infection occurred about 2 weeks prior to symptom onset. Initially, there may be symptoms of hyperthyroidism with elevated FT3 and FT4 and suppressed TSH on laboratory testing. The erythrocyte sedimentation rate, ESR, is a nonspecific marker of inflammation and often elevated in this condition. Sonography may also be very helpful. Typically, it shows patchy, map-like hypoechoic patterns in the thyroid gland with a normal blood flow to the thyroid. Because many thyroid cells are destroyed, large amounts of thyroid antigens enter the bloodstream. As a result, thyroid autoantibodies such as TPO antibodies may be detectable, as seen in Hashimoto's thyroiditis. However, this usually does not lead to a manifest chronic autoimmune Hashimoto's disease, since the pathomechanism is different, and experts say that also in Hashimoto's disease, autoantibodies are rather a byproduct and not the primary cause of inflammation. Subacute or Quervain thyroiditis is usually self-limited. In most cases, only symptomatic treatment for pain and fever may be required. In more severe cases, glucocorticoid therapy may be necessary to reduce the inflammation. Let's summarize. Subacute thyroiditis or Quervain thyroiditis is not a chronic thyroiditis and most likely occurs post-infectiously after an upper respiratory tract infection. The inflammation leads to severe anterior neck pain, often accompanied by systemic symptoms and fever. There may be an initial hypothyroid phase, followed weeks later by a transient hypothyroid phase, which usually resolves spontaneously. The diagnosis can often be made on the basis of the characteristic clinical presentation, but ultrasound is very helpful as well. An elevated ESR sedimentation rate can also support the diagnosis. In most cases, treatment is purely symptomatic, but in severe cases, therapy with corticosteroids may be required. If you have any question, feel free to write a comment, and I see you next time.